Okay, so like Tammy said, I'm a neonatologist, newly a neonatologist, and I do ethics research mostly around how we use genetic information in the NICU. So I'm going to start with a few stories of children that I've taken care of in the NICU, and I think some of the themes will hopefully be familiar to you from your own experiences. Hold on, let me just make this more. Okay. So the first baby that I'm going to talk about was a baby girl who was born with akinesia. So she was born in the special delivery unit at CHOP, which is a place where children are born if they have prenatal diagnoses that we know will require coronary care. And she had numerous anomalies that all had been noted prenatally. She had increased bone density on x-rays, aortic arch hypoplasia, and a VSD. But the most notable feature of all was that she just hardly moved at all. And her mother said that in the pregnancy, she had actually recognized this. She'd had an older son too. And she realized that her daughter had really moved so much less than her son. Like she almost never felt her move when she was pregnant. So in some ways, she wasn't surprised when she was born and she really never moved. At first, we had a lot of discussions with this family about like what was the right way to care for this baby girl. And they had a clear compass that they wanted her to have a life without a lot of medical technology, at home with her family, and that they really didn't want her to have a tracheostomy. So ultimately, she had exome sequencing, which returned during these conversations and showed an X autosome translocation, which I was actually helped write the case report, and I wouldn't have known much about this specific genetic change had I not. But it turns out that this translocation rendered a number of genes non-functional, and the constellation was rare, but we knew that because of the genes she was missing, that she would have really profound disability and probably never develop the ability to breathe on her own. So we had a really amazing family meeting with this family, who was Spanish speaking, and we were lucky to have a great interpreter. I know it doesn't always work out that way. And they really decided that this wasn't a path that they wanted for their daughter, and they held her, and everybody cried, and we removed her breathing tube, and she passed away in the NICU a few days later. So the second story is of a baby who was transferred to CHOP soon after birth for micrognathia, or as we all know, is a small jaw. And he was on CPAP until he had jaw distractors placed. And a microarray was sent around the time of his admission, as part of our micrognathia pathway. He had had the distractors by the time it resulted, and the neonatology team, the genetics teams, and the boy's parents all met to talk about the results. And the exact deletion hadn't been reported before, but overlapping deletions had been associated with pituitary gland anomalies and mild variants along the holoprosencephaly spectrum, with developmental delay of varied severity from none to sort of moderate. His dad asked where he should expect. First, he asked some questions about a pituitary. We explained what it was, and then he asked about what sort of disability he should expect for his son, and we explained that there was unfortunately really no information to answer where his son would fall along the spectrum. And as I walked the parents back to the baby's bedside, he took this big stack of papers with the genetic results that had been given to him in the meeting, and he slipped it in the trash and kept walking. The third case is a case that is currently in a baby currently in the CHOP NICU, so I will talk about it only in very vague terms. The other two are published, so it's okay to talk about a little bit more specifically. But this is a baby who was recently born with coarctation of the aorta, a single kidney, and an imperforate anus. A whole exome panel recently returned. So the baby had been maintained on prostaglandins for about a month, with kind of consideration of whether he would be a surgical candidate. About a week ago, here, maybe 10 days ago, his whole exome, we were doing this like whole exome panel, whole genome panel, that is sort of it's a 3,000 gene panel on top of a whole genome backbone. Anyway, it comes back a lot faster. So his came back and it showed 2 deletions, which hadn't been reported before together, but were independently associated with various developmental disabilities and also some of the physical anomalies that he has. And the next day, the cardiac surgical team decided that because of these changes in conjunction with this whole clinical picture, he was not a surgical candidate. The parents have pursued several other second opinions at 3 or 4 other institutions, and those are ongoing. But so far, the patient has been deemed not a surgical candidate. So in all 3 of these cases, what really is genetic information doing? How are we using this information about the future? And how certain is that information about the future? How do we use that information when it contrasts with what we see clinically? These are really the kind of questions that motivate me to do the research that I've been doing for the past few years and continuing now. So we'll talk about some of these questions throughout this talk, although if I'm at all successful, I'll probably hopefully leave you with more questions than answers as to how we really use this information and how we should be using it. So the NICU is a launching point for genetic information for a variety of reasons. As we all know, the neonates, particularly those in a high-level NICU, are concentrated population of babies that have genetic changes. So there's a high prevalence of various kinds of genetic disorders. Many studies have documented that if you do broad bandwidth testing like whole genome or exome or a large panel, you will find a high proportion of these patients that do have genetic changes in just kind of at large. At the same time, the NICU is a place where we need prognostic information. So we're often kind of operating with incomplete information, unlike other medical contexts. We don't have a prior baseline. We don't have kind of a known life that this child has had before they come to our hospital. So we're often trying to think about what the future is going to look like when we don't have much information about the past or about what that child's really doing. And as we know, babies can't do much of anything, even in the best of circumstances. So it's not like we can look at a child and say, like, what is this child's life like? It's often about the future. And I think that's where genetics holds a lot of promise to sort of tell us what's that future going to look like. At the same time, there's been evolution of genetic technology. So even in my relatively short career so far, there's been, a shift toward being able to do much broader testing and being able to get those results much faster, such that they can at least potentially be used in ICU decision-making, a place where we know that information on the scale of months isn't very actionable. But genetic information is complicated. There are a broad array of genetic tests that generate an even broader array of diagnoses. And what we do with all of these diagnoses is not always clear cut. So with many other kinds of diagnostic tests, for example, we're trying to evaluate if a patient has something we're thinking about, because if they do, that would have a clear implication for their treatment course. And that is true for a subset of genetic diagnoses. For example, CHOP sees a lot of patients with hyperinsulinism, and if we know what type of hyperinsulinism they have, it informs which imaging we do and which surgery they might or might not have. But for many genetic diagnoses, this isn't the case. We're sort of getting information about what caused the constellation of symptoms and sort of a big picture sense of maybe what the future might look like is what we're kind of hoping for. But then what we actually do with that information is a lot less clear cut. And as probably as on neonatologists, we've probably all seen that, the information is complicated. Sometimes it doesn't neatly align with the reason that we sent the test or the clinical picture that we see. Or sometimes we don't actually have that much information about what that specific genetic sequence, genetic change will mean for this individual child's future. And we are operating with a great deal of uncertainty, even outside of the obvious context of like a variant of uncertain significance. But even if we have a real diagnosis, that kind of uncertainty often is persistent. And so, like all complicated information, applying this to clinical care has both potential benefits as well as potential downsides. So I'll outline this talk by talking first about the difficulty of measuring the benefit of genetic information in the NICU, and then talking about a few potential harms that against which we have to weight all benefit. And I'll mix in some of my own work with some other work in this area, but I can't do nearly justice to all of the work that exists in this area. So if people have other questions, I'll take them about sort of related work, I'm happy to answer at the end, or I'll give you my email too for anything else. So first, how can we measure the benefit of genetic information? So I talked about those three cases at the beginning, and in some ways, in all cases, we would probably say that the genetic information was providing prognostic information. But obviously that prognostic information has different value, or I will argue has different value, and certainly it's obviously doing a different job in the different cases in terms of what actually happens after the test is resulted and how clinicians are using that to counsel families and make decisions themselves. So to take a step back, utility is the likelihood that a test will result in improved outcomes. This is pretty easy to conceptualize for something like a cancer screening test. So we have a new cancer screening test. We see how well does it detect cancer? How much earlier than the prior kind of testing can we detect cancer? And then what are the benefits of detecting cancer early in terms of survival, in terms of surgical outcomes, really all the downstream things that happen after you diagnose a tumor. And then we can weigh this against the potential harms of a diagnostic test. So for example, the risk of false negative and that causing people to worry or have an unnecessary biopsy, et cetera. But for genetic tests, it's a little bit more complicated. First of all, genetic tests can result in a broad range of diagnoses and therefore a broad range of changes in care. So we can't tie the utility to one easily measurable outcome. Second, commonly applied outcomes that could be applied in other sort of as summative measures in other contexts that have not one clear outcome are things like length of stay or quality of adjusted life years. But the goal of genetic testing is not always to decrease length of stay nor to increase or prolong life. So that doesn't really work either. So what we've really settled on is intermediate outcomes like diagnostic yield or process measures like changes in management. But I will argue that these are actually poor proxies for true utility. Like I pointed out, the three cases that I talked about at the beginning, you could say all of them are a change in prognosis, but obviously this is having different effects. And it doesn't really make sense to count all three of those results in the same category. And then I think the reason that it's really the hardest to measure the utility of genetic information is that it's informational at this stage. So there are the cases like the HIs or here also lymphatic disorders where the genetic result is leading to a clear change in therapy and we can measure the effect of that therapy, but those are a minority of cases, even of positive tests. And in a lot of other cases, it's just giving us information about what caused this, about what the future looks like, without changing maybe what we're doing today. And that is a lot harder to measure. So through my ethics training, I read a lot of these complicated frameworks of what it really means to have utility for genomic medicine. And they kind of address all the things I've talked about that, it's hard to measure this value of information. And at the same time, I worked in the NICU and read the whole exome and genome sequencing studies in the NICU, and I noted discrepancies in how we actually are attempting to measure utility. How are we measuring utility? So to get at this in a more systematic way, I conducted a systematic review of prospective studies of whole exome and genome sequencing in critically ill neonates. And I included all studies that were sort of NICU patients at large, not a specific patient population, like, for example, not just patients who had seizures, but patients at large who were making a whole bunch of different kinds of diagnoses, like how in those studies, the very studies that aim to prove utility, are we actually measuring it? We created a standardized framework. So I did this with one of my ethics postdoc co-fellows. And we created a framework for sort of the most common reported buckets or types of utility. And then we tried to fit each patient's reporting into these buckets. which I'll present in a second, as a way to like combine them, although it's not a true meta-analysis because the papers were too different to actually perform meta-analysis. We also extracted information on the patient cases or examples of utility that authors chose to highlight. So some authors did this by providing additional clinical information about a case or calling it out in kind of a figure or box where they would say, like, this is a case of utility that we're highlighting, presumably because they think those are particularly good examples of utility or cases where genetics had a really positive impact. And in that subset of highlighted cases, we also looked at kind of like what buckets are present and at what frequency are these buckets of utility being represented. We searched 4 databases in one register and ultimately included 21 studies representing over 1,600 patients. So notably, only 70% of these papers only looked at positive genetic changes or positive genetic test results. The rest only looked at patients that had both positive and negative results, and none of them explicitly said what they did with uncertain results. The ways that these papers reported utility were similar enough that we could put together these buckets of utility types and then collate the patients between studies. So for example, like this study reports 4 changes in medication. We'll count that as a treatment change and we'll put it in treatment change bucket. And using this framework with 2 reviewers, we were able to combine the studies. And as you'll see here, the frequency of the different types of utility is very variable, with reproductive information and prognostic information being far more common than screening and referral, treatment change, and redirection of care. This figure compares the overall utility to that highlighted subset that I had mentioned of cases that were highlighted by the authors. 9 studies included 1 or more such cases. And as you'll see here, the types of utility in the highlighted cases way overrepresented treatment changes and underrepresented screening, reproductive, and prognostic information. They also interestingly overrepresented redirection of care. So in short, utility is important, and every study we looked at made some effort to identify how this test is actually changing patients. The goal of genomic medicine is to improve care for patients, and they all make an effort to document doing that. Studies used common categories of utility, of which informational types of use were more common than action-based types. So just having prognostic information is more common than having a change in a current therapeutic. And all of these frameworks emphasize change over value. So we say we're changing a medication, but let's say you change a medication, an anti-epileptic, and a child never has seizures again. Well, that's a really wonderful change. But then let's say you change an anti-epileptic and the child continues to seize the same day. Well, I would argue that we should count that as a far less meaningful change. But in these kinds of frameworks, those are basically being all counted the same way. Similarly, all the prognostic information I discussed at the beginning is largely conflated into the same kind of bucket of either prognostic information or maybe for the last case, 2 of the cases, redirection of care. And then all of the types of utility, so change in management versus prognosis, et cetera, are basically counted the same way in current metrics. So at the same time, I think common sense will argue that, some of these changes have a much more profound impact on like the patient's course in the NICU than others. And the highlighted subset suggests that the authors agree that some of these, like a change in treatment, seems to be of greater value than simply having reproductive or prognostic information, which makes it feel not quite right to add them all together. I think what's more important really is that many things are omitted from this. And to me, probably the most important is that utility, to me, of genetic medicine actually has a lot of, there are many other types of utility than just changes in management. So I think sometimes just having a clearer framework of how we're thinking about a patient or a clearer framework for counseling a family can actually be of great value. But outside of this kind of general prognosis, changing prognosis, we don't really have a way to communicate that in this type of research. Second, we often talk about the value of genetic information for families when we're citing reasons to do it, but in the actual studies that aim to document this, we don't really talk much about personal utility or family perspectives. Third, the utility of negative and uncertain results, which are a majority of results, are largely ignored. And fourth, we don't make any measure of potential downsides of having all of this complex information in these kind of studies. And that is what I'm going to get to in the second part of this talk. So to have better measures of utility, there have been a number of efforts to develop more robust questionnaires that try and address some of the limitations. And we're working on one at CHOP in conjunction with the Baby Eagle Project, which is the testing that I referred to, where it's a 3,000 gene panel on a genome backbone. So they just look at 3,000 preset genes, but it's on a whole genome backbone. And I had the opportunity to develop the questionnaires for this. And we tried to address some of the limitations I've discussed before. So in this, we're actually sending the questionnaire to both clinicians and parents, so we'll be able to compare them. We ask about both positive and negative effects of the diagnoses. And then we also did try and ask about benefits that may not necessarily be change in management. And we've only gotten about 20 responses so far. We just started this, but this is really just to show that if you change the questionnaire, you will change the output you get. So parents do report positive effects, and the most important is, or the most common is, a clearer sense of the future, but at the same time, they also do report some negative effects. And interestingly, the most common of those is feeling more confused about the future as a result of genetic testing, which I think gets to sort of some of the ambiguity that you probably noticed in the first few cases. And then clinicians also do report positive effects, but mostly these are actually not changes in management. And the most common is just having confidence that they're not missing anything, which, as anybody learning neonatology, you'll know is worth a lot when you're really taking care of sick patients and trying not to miss anything. Okay, so now I'm going to move on to talking about some potential harms of genetic testing. I do want to highlight one sort of concept in this, which is genetic exceptionalism. So there's been a lot of discussion in the ethics genetics literature about this idea of genetic exceptionalism and the fear that genetics is held to a different ethical standard than other types of medicine. And certainly I think that would be inappropriate. It shouldn't be held to a different ethical standard. But I do at the same time think that genetic testing plays a different role in the NICU than a lot of other types of tests. Probably to me, the most similar would be brain imaging. But even then, we kind of have a little different sense of like what we're hoping to get from that test. Sometimes I would argue we have a clearer question that we're trying to ask. So I think at the same time, it is warranted that genetics gets some particular thought as with implications for both families and clinicians using this complicated information. In the interest of time, I'm going to go through this part relatively briefly. So one of the biggest potential harms of genetic testing would be that we all agree that there is benefit for many patients, and it's possible that this benefit isn't equally being borne by all patients. There are two ways that this could operate, or probably even more, but two that I'll discuss. The first is that the actual testing could function better in patients of majority versus minority groups because of the way the actual test has been researched and designed. And this is a long-standing concern, which stems from that people who are of white European ancestry are overrepresented in the genomic databases that exist currently. And this is a study that I pulled out from a little while ago that just really shows that in minority populations, genetic results are more likely to come back as inconclusive, and that is just because we have less information about what is the typical alleles in that gene pool, and therefore, like, we just are more likely to get an uncertain result. So it's possible that the testing could actually work less well in this population, in minority populations. I also did some work to look at access to testing. So I kind of went into this thinking, the NICU is actually a place where genetic testing, we would hope, would be somewhat more equitable because patients are already in the hospital. There are different insurance regulations, but at the same time, it's possible, like, we see a lot of variation in genetic testing practices between different NICUs, and it is possible that exists such that certain patients who would be deprioritized in terms of their access to genetic testing, and that a baby born in two different hospitals, just by virtue of where they were born, would have a very different chance of receiving a genetic test, just simply based on that, and that would kind of act in a systematic way. So I got at this question a little bit in a review I did of the FIS database, which is a publicly available database of 40 pediatric hospitals. And here I researched the variation of the proportion of patients that get genetic testing in different NICUs, and then did a multivariable, multi-level regression model to try and control for some hospital level illness severity factors and see if that was it just that some NICUs do more testing because they have sicker patients and more likely to have genetic disease, or was it really kind of couldn't be explained by that? Overall, 13% of patients had some genetic testing. And here each line represents a hospital. And as you can see, the percent of patients tested at each hospital is variable. It goes all the way from 4% to 40%. And the top dotted line here, I don't know if you can see this. I think you can see my arrow. The top dotted line is the 5 highest testing hospitals, and the bottom dotted line is the 5 hospitals that tested the lowest percent of patients. And concerningly, you can see that instead of getting narrower, the gap is actually getting wider. So some NICUs are testing a lot more patients than other NICUs, and this could be for a whole variety of reasons, but this sort of just documents that it's happening, as does this, which is the same thing, really just shown by the percent of patients tested. We looked at a number of characteristics that could potentially explain why some hospitals tested more than others, and we found that, as you might expect, hospitals with higher mortality, higher number of complex chronic conditions per patient, congenital anomalies, and severity all tested more, whereas those with lower gestational age were less likely to have genetic testing. This is at a patient level. And interestingly, those patients who self-identified or their parents self-identified as Black were also less likely to have genetic testing. But even when we controlled for these characteristics, the variation still remained. So it went from like 13% to 10% variation was still unexplained and was just existed at a hospital level. So what does explain variation? It's possible that there are, different reimbursement policies. There certainly are different reimbursement policies in different states. It's possible that some hospitals have better access to genetic subspecialists. It could just be idiosyncrasy. I think some of it probably is, like this hospital currently has a genetic initiative with a lot of testing paid for by the hospital, whereas other hospitals might not. And then it is finding that Black race correlated with a lower likelihood of genetic testing also raises the concerning possibility that there could be biases at play here. So this is an area that definitely needs more work, but I think currently there are no clear guidelines for who receives testing. So whenever that sort of situation exists, it's likely that there's a lot of variability, and variability usually works in a direction of making of exacerbating inequity. So that is, I think, an important area for future direction. Gonna move a little bit quickly through to this part. Okay. So, as we all know, as neonatologists, we don't receive that much genetic information. And so it's possible then that we are just misusing it because we don't totally understand it. And the little few slides I skipped over were really talking about how I did a survey of neonatologists, and there have been some other similar surveys too that really just point out that neonatologists are increasingly expected to counsel around genetic testing and understand genetic testing themselves, as there's more and more of it done in practice. This also led me to the concerning possibility that neonatologists might, in certain situations, misapply genetic information, and particularly misapply it in ways that reveal ableism and bias against people who are expected to live with disabilities. So I really got started thinking about this in residency when I was on my development rotation. And I was working with an older attending who still kept paper files. And in one of the files, she had an article by the mother of a patient we were about to see. And this mother turned out to be, by chance, a disability scholar at Columbia, Rachel Adams. And she had written this article about her son Henry and his love of the Muppets. A world where Henry, who has Down syndrome, feels totally accepted. And she wrote about kind of his experience with the Muppets and how this contrasts to sort of the way he was seen in medicine. So I ended up working with Rachel and doing a project on Down syndrome that resulted in us writing a family partnership article together. And since the whole point of that sort of article is to give a direct voice to families, I'll read a quote from Rachel that really this whole project was sort of the impetus for me thinking, how do we use genetic information in thinking about patients' future? So just keep that in mind as you listen to the quote. So Rachel writes, "My son will tell you that he has Down syndrome and that it is caused by an extra chromosome, although he has trouble saying chromosome, so I help him by tapping out the syllables as he speaks. He is proud of sharing his identity with his friend Aiden and John, a teenage neighbor he admires. We speculate that Yoda and the Minions, two of his favorite movie characters, have it too. Sometimes he stops in the middle of our conversation to tell me, 'Mom, you are so beautiful,' a phrase he also uses to avoid doing his homework and putting away his iPad. I could imagine none of this 11 years ago when Henry was diagnosed with Down syndrome at birth. Although Henry was not critically ill, he was immediately whisked away to be examined and monitored by a battery of specialists under the hospital's Down syndrome protocol. When a parent's first introduction to our child is shaped by doctors trained to seek out pathology, there are unintended consequences. We come to know our children not first as children and not as new members of our family, but as potential sufferers of illnesses and delays. I myself, 7 years into medical education at that point, had almost no education about Down syndrome, except for risks associated with future complications. And I had very little teaching about disability more generally. So I really got to thinking, I had previously done some work on integrating genetic information into complex medical practice. And I thought, well, maybe this is kind of an area where we're a little stumped and we don't all have the background that would be necessary, or I'm not even sure how you could have the background to be necessary to really, in a very balanced way, integrate this information into clinical care. So my first project in fellowship was to evaluate the hypothesis that neonatologists apply genetic findings to clinical decisions in ways that are unsupported by data or make ethically questionable assumptions. And to do this, I used a split sample experimental design. So I distributed a survey to neonatologists through 2 listservs, one of which was the AAP. And there were 2 versions of each hypothetical vignette. So we talked about a patient case, and there are 2 versions of each case. And they vary only by one thing. And that was whether they either had the presence or absence of some genetic information. And I'll refer to those as the genetic and non-genetic groups. So like, let's say the first half of you see this patient case with no genetic information, and the second half see the same case, but now there is some genetic information. You don't know which version you're seeing or that there is another version. And then I compared the responses on the other side. And the responses had to do with what recommendations people would make for the care of the child described. So the first case aimed to determine whether the presence of a variant of uncertain significance affects our recommendations about both invasive care, intensive care, and about palliative care. And our hypothesis was that including a variant of uncertain significance in a scenario would make neonatologists less likely to recommend continued invasive intervention. So this case describes an extremely preterm 23-week infant with chronic lung disease. And it asks the neonatologist whether they would recommend a trach and G tube, and separately, whether they would recommend a transition to palliative care. In one version, there was a VUS in a gene that is associated with pulmonary problems. And in the other, there was no VUS. And as you can see here, our hypothesis was confirmed that the genetic version, clinicians were more likely to recommend redirection of care and less likely to recommend the trach and G tube. And by definition, this isn't supported by sufficient evidence because the consensus among geneticists is that VUSs shouldn't be incorporated into clinical care. The purpose of the second case was to determine the degree to which genetic diagnoses that portend future neurodevelopmental disability bias clinicians to offer less invasive care, even when those diagnoses aren't expected to affect acute survival. So in this case, we described a 2-week-old extremely preterm neonate who has sepsis and needs more access, and they're having trouble getting access, and we asked them about whether they would pursue a Broviac line for a patient. And in one version, the child had Williams syndrome, which was incidentally diagnosed with no heart defect. And then in the other, the patient had negative genetic testing. Here's Williams syndrome. In the genetic version, again, neonatologists were less likely to recommend invasive care and more likely to recommend palliative care for the child who had Williams syndrome. So this confirms that an incidental finding with neurodevelopmental implications, even relatively mild ones, like those associated with Williams syndrome, would be associated with favoring palliative care versus invasive care. So this is all data from a hypothetical questionnaire. However, if these sort of findings extend to clinical practice, the implications are concerning. It suggests that uncertain data is not just sort of ignored, but actually integrated into care in ways that reflect confusion and bias, and that ableist bias actually affects the way that we interpret genetic information in clinical practice. And it really suggests that neonatologists need more support in using genetic information to make these kind of decisions, and that having more and more information, has trade-offs. So I'm going to skip talking about my current work, which I'm really just beginning, but focuses on kind of how genetic information itself has a lot of uncertainty in it. And I'm trying to get at what sorts of uncertainty are problematic to parents using that information and also to clinicians using that information. And really so far just it's been really interesting finding that, different sorts of uncertainty, different kinds of questions that we aren't able to answer are troubling to the two groups. And so more to come on that, but I want to leave a lot of time for questions. I have a lot of people to thank for helping me accomplish any of this. Most of all is Chris Feutner, who's my primary research mentor, and that would be my #1 advice to anybody trying to do research, is to just have a research mentor who you really trust, who's willing to invest time and kind of take a gamble on helping you do your work, because I would not have been able to think through much of this without Chris. And then here's my email address. I really mean it. I'm happy to answer any questions now, but you're also welcome to reach out after. So I'm going to try now, let me see, to stop sharing my slides so I can see people, and then I'm happy to take any questions.
Thank you so much, Dr. Callahan, for a wonderful presentation. If anybody has questions or comments, feel free to put them in the chat. You can also raise your hands, and then I, as the host, can unmute you one at a time so we're not all jumping in at the same time. I wanted to ask a question just to get us started a little bit about changes in the language that we're using with genetic testing, using words such as variants rather than mutations as a way to maybe address some of our ableism, and how have you found language to play a role in genetic testing and counseling for families, both in your own practice as well as in your research?
Yeah, I think that that is a really like good point, and I think we should be careful about our language. Something that I've found interesting in doing the interviews I'm currently doing with families is that they do talk about um mutations and kind of like they're almost more blunt with their language, and I think actually families don't like us to kind of skate around like what we're really saying. So like talking about like when a baby has like a really severe congenital defect and then we find an associated genetic condition and we talk about like, oh, this is a genetic difference. Like, I think on some level, like it's sort of skating around the main issue, which is that like we need to be honest and open in our conversation about what we know and what we don't know of a disability, and like just using kind of fluffier language doesn't really address the underlying problem. I actually in some separate work, I'm doing a project to ask families what language around disability they like to hear. And I kind of went into it thinking like, oh, families are not going to want us to just say like, your baby's not going to be able to walk or talk. And a lot of families have sort of reported that language back and said that they felt it did communicate something very concrete and useful to them. So I don't know. I think it's difficult to answer without like just empirical data of asking parents.
I'm just scanning to see if we have any hands raised. And if everybody could take the time to copy the link and complete the evaluation, that would be much appreciated. Um, the other question I was wondering was with regards to your findings about genetic testing across different hospitals. It did kind of seem by the individual lines that a lot of the difference was driven by maybe two hospitals, just like all of a sudden accelerating their amount of genetic testing. I wondered if you looked at all into that, and then also your thoughts on the difference between genetic testing at academic centers where we do have geneticists and genetic counselors that can support both the decision to do genetic testing with the family, as well as interpreting the results versus a hospital that's non-academic potentially.
Yeah. So here's the data. I can share the slide again. I do agree that there are some real outliers in the positive direction. Actually, I don't see an option to share it anymore. Um, hmm. Can I just copy this? Let's see. What I wanted to the point I wanted no, I can't. What I wanted to get across is that there are like two or three hospitals that test kind of 40%. And then there are a whole bunch that test somewhere between 25 and 5%. And I think that is probably, you're right, like where the most interesting section is like, why do some test 25 and some 5, not these two kind of outliers? And I do think a lot of it is from kind of like if one hospital has a sort of real advocate for genetic testing and somebody who has a very strong relationship with the genetics department or gets funding to do a genetics project, like those are kind of outliers in the positive direction. And I agree with you totally that we shouldn't be doing testing that we don't have the support to um counsel about on both before and after the testing. But then I think the answer to that isn't that that's a reason we should do less in certain places. It's that we should try and come to some consensus about ideally like when is testing beneficial, and then when like some more clear consensus about what patients should be tested, and then it's our obligation to provide the required support that goes along with that testing.
Thank you. We have a question from Heather French in the chat. She wanted to know your thoughts about cost effectiveness of genetic testing for a patient, that's not, I think maybe she's asking about sort of non-targeted, potentially phenotypic testing.
Yeah,
But the question is a patient that doesn't have any leading diagnoses.
that's a very good question. And I think an important area. So there has been a lot of work to try and document cost effectiveness of genetic testing. And it very much hinges on kind of the utility work, the utility frameworks that I showed earlier on, and like proving that we're shortening length of stay, proving that we're improving treatment. And I think all of the inadequacies of our current utility metrics make it almost impossible to actually do a good job of showing the effects on costs. And I think ultimately that we're not at a point where we can really consider cost effectiveness. I think we need to focus for now on like, who is this having benefit for, and kind of come to some consensus about that before we even try to prove cost effectiveness. Because, for example, a lot of those studies, the biggest driver of cost effectiveness is reduced length of stay from redirection of care. But most of those studies don't even explain what exactly is the rationale for redirecting care. And if it's about like, disability, like that could be appropriate or could be inappropriate, but would require careful consideration. And I think it's hard to just on face value count that as a benefit that we reduce length of stay by redirecting care sooner. So I think I agree that that's a really important question, especially as we spend a lot of money on genetic testing, but I just don't think we're in a place to like really address it yet.
Thank you. Any other questions, throw them in the chat, or feel free to raise your hand or unmute yourself.
Is anybody else doing any kind of ethics-ish related research in this group?
Dr. Callahan, do you have any parting words of wisdom or last thoughts as we close out the session?
I really don't. Thank you very much for having me. If anybody has any questions, they're welcome to email me. I think if you have any sort of research interest, that is, Danielle, I already know and reached out to me on this exact question, but if you have any kind of research path that isn't like the most traditional research path and you don't have somebody to ask about it where you are, I'm happy to be a resource. So feel free to reach out.
Thank you so much, Dr. Callahan, and thank you everybody for coming. We still do have a couple more minutes if there are any other questions. I was going to ask if you had any thoughts. I think there's a lot of uncertainty with regards to variants of unknown significance, any variant actually that could even be pathogenic. But there's also, I think, a lot of uncertainty for diagnoses that are well established. I'm thinking of trisomy 18 and the sort of genetic fatalism that we can sometimes apply to disease or conditions that we know a lot about, but are ever changing in terms of management and families' decisions, in terms of how they want to proceed with decisions for their child. So I wondered a little bit about how you feel the differences there, new things that are fresh off the exome sort of diagnosis versus some things that we like know very well and are familiar with, but we may be counseling in a different way because we think we know.
Yeah, no, I think it's such a good question. And their unifying theme of what you're saying is that we generally think that genetic means bad. And even outside of, for example, like a baby that has many anomalies and has a negative exome, like something about that baby that has a known genetic problem is bad. And I think that has to do with some, like, our ideas about inheritance and ancestry are like millennia old. Like for millennia, people have been trying to kind of think about what makes people unique and like what is the role of heredity in that before we even really understood about genes. So there are some sort of deep-seated notions of like a genetic change being a bad one. And I think now that we have all of this information, it's manifesting in new ways. And it's just something that we really have to be aware of and be careful about and recognize is happening as we get more and more genetic information, because I don't think there's going to be like an easy solution to sort of correct for that bias other than just as a base starting point, trying to be aware, like question your own thinking. Why am I really recommending what I'm recommending? Is this genetic change really worse than something else that I might see clinically? And trisomy 18 and 13 have certainly been a good example of that. Even trisomy 21 in, a couple decades ago of kind of rethinking, like, why did we think this genetic change was perhaps even worse than the actual phenotype would suggest? Okay, thank you for having me.
Yeah, thank you so much, Dr. Callahan, and thank you, everybody. Please click the link and complete an evaluation, and thank you all for coming. Thank you.
Thank you.
Yeah, of course. I'm gonna stop recording,
Did a
I
great
think.
job.
If I can I? I know I can do this. Stop.